So I want to cover two trials, this one and then piece 3, which is important, that we alluded to. So this was UpFront PSA. This was Arun Assad. The Australian group's done a lot of these investigator-initiated randomized phase 2, the therapy and this one, and I think others, Enzapi, if I remember correctly. This was hormone-sensitive disease, so to my knowledge, the first experience with lutetium PSMA and hormone-sensitive disease. High tumor PSMA uptake, I don't have the definition there, and high volume disease because it was docetaxel based, either standard ADT docetaxel, that should say, or adding two doses of lutetium PSA before the docetaxel. And we did a podcast with Arun, and it was really just sort of a very practical decision of, well, we don't know how many to give. Maybe we can't give them at the same time, so let's give 2, which is totally understandable in an IIT. They looked at undetectable PSA at week 48 as the primary endpoint, which we can talk about. You see there was a significant difference, 41 versus 16%. You see the other PSMA parameters there. And then PSA progression and rPFS in the Kaplan-Meier curves. I basically summarized a ton of data on this one slide, including sort of the bullet points. So and the next slide is on PSMA addition, which we'll talk about, but how does this help us? It was safe, right? There was a little more cytopenias, as I remember, but there weren't big toxicity signals. I know Michael's opinion, Tanya. I'm looking at you. I don't know if you have an opinion on this.
I think it continues the story that we've been seeing in the metastatic hormone-sensitive prostate cancer space, which is that more treatment up front is helpful, that we want to try to debulk as much as possible and achieve a deeper remission. But this is not a regimen. ADT docetaxel alone is not a regimen now that NCCN recommends. So unfortunately, clinical practice evolved during the time period after this was developed. And so it doesn't answer the question of, in the context of using an AR pathway inhibitor, would we have gotten the same results? But I think it just tells that same story that we're seeing over and over again of intensification.
Michael, is it really just mostly about feasibility, safety?
Designed, yes.
Yeah.
If you have a biochemical time to BCR failure, which isn't biochemical relapse-free survival even, right? It's just time to the PSA. That's really not a clinically informative endpoint. So that this is going to just speak, in essence, to feasibility. I think that this is where the rubber hits the road in terms of how do you design an early phase trial with information that will allow you to say, is this a go, no-go decision? And I think you have to have some respected either clinical or regulatory recognized endpoint to inform you of that. That could be rPFS, that could be, if it's an even earlier treatment population, MFS for the non-metastatic group. But I don't know what to make of this. And in the end, first of all, PSA, time to PSA progression has not been a reliable predictor of a phase 3 outcome. Time to castration resistance is even more poor because many patients spend more time in CRPC now than they do in CSPC. And I think that it's great to have shown the feasibility of this. I don't think that's on the slide, but quality of life was the same of the two groups.
Yeah, just a bullet point.
If you're not improving how patients feel and you don't have the clinically informative endpoints here, then it's tough to sink your teeth into where you go with this.
Yeah.
But I do think for a primary endpoint of undetectable PSA at week 48, we have data across multiple trials charted, that do show it's predictive. And so I think for a short signal-seeking early stage trial, I think it was a very reasonable endpoint and clearly showed efficacy for the combination over upfront docetaxel, which arguably is the standard of care now. But I think you can't get too lofty in a phase 1 as to what you're going to get at it in terms of rPFS.
Yeah, fair enough. This is PSMA addition. I don't know where this stands in terms of timeline, if anybody knows or can say, right? But this will be presumably the definitive test of lutetium PSMA in the hormone-sensitive setting. Obviously, this is different than the UpFront PSMA we just looked at, this is the same Q6 weekly, 6 doses plus standard of care. Primary endpoint RPFS, obviously OS as well. Predictions whether completed accrual. Okay. They probably allow people that started hormones within some period of time.
Right.
Just a practical.
Yeah, so the reason, well, I have to stand behind it, sorry. So, no, Scott is, but the reason for that is that many patients, for their primary disease, will get radiation and hormonal therapy, and then will develop metastatic disease. So the aim was not to exclude those patients who may have received hormonal therapy up front for their primary treatment and exclude them from this trial when they metastasized. And you'll see that there's a little footnote there, Tony, for minimally treated as to what it means, and that footnote is defined in the protocol as no more than X number of months. So.
You guys, unlike kidney, where we're black and white, it's just not.
But I'm on the stage with these guys here. Throw me under the bus.